It is 9 p.m. Cairo time. Welcome to the Watany Web Week. Session is part of a whole week-long sessions that is organized by the Watany Eye Hospital in Egypt, one of the leading institutions of ophthalmology in the Middle East, as you must be aware. Tonight we are discussing glaucoma, and I am privileged and honored to be in the company of great men. So we have fantastic, really good surgeons from all around the world. We are having European participants, we have Middle Eastern participants, we have North American participants. So I think this should be a very interesting night and a very good learning experience for all of us. I will kickstart with a man that I admire significantly, I have to say, and have been following his exponential rise in the world of glaucoma, Leon O from the UK, who is going to share with us some of his vast experience. He's a very shrewd and a clever surgeon. Leon, please.
Thanks, Tarek. Hopefully I'll be able to share my screen. Let's go back a bit first. Finally, are we good?
Yes.
Thank you. Thanks, Tarek, for having me on here. I'm going to kick off. I think we're all about talking complications. So I'm going to kick off with one of the complications that hopefully is not that common, but maybe more common than you think, is malignant glaucoma, or often we call it aqueous misdirection. I'm not going to claim to be the world expert. Hopefully none of us are going to be world expert, because something that we really don't like to see. But nonetheless, when it comes to glaucoma world, when it comes to filtration, when it comes to plumbing, we're all going to see it, certainly with the eyes that we deal with. Usual financial disclosure, none of it is related to the talk that I'm going to give you today for the next 9-10 minutes. So aqueous misdirection is often the name, which I think is slightly better than malignant glaucoma, which sounds a bit sinister and cancer related. And of course, because there's nothing to do with cancer. Aqueous misdirection, it makes more sense because it is about the misdirection of aqueous. The mechanism, we don't really fully understand. We all have our theories and ideas, but ultimately it's about the aqueous, rather than coming through in front of the lens, through the pupil into the anterior chamber, somehow it's becoming misdirected and going posteriorly to the posterior chamber behind the lens into the aqueous, either into the hyaloid phase anterior to it or into the vitreous cavity, swelling everything up. And then that build-up pressure at the back of the eye pushes everything forward, either being your IOL or your natural lens forward. So then there's a posterior rotation of the ciliary body, we think, aqueous jetting back to the posterior segment. Your either natural lens or your IOL get displaced forward, and you get a secondary angle closure with or without some raised pressure, but normally we see it with high pressure. So that's a sort of aqueous misdirection that we all know about, but we don't actually fully understand why it happens and chicken and egg scenario in terms of what brings it on. Someone else once told me, and I quite like the idea, that it's a bit like a rock in a stream. So if you look at this classic picture, there's a rock in a stream. The fluid, the water is flowing from your left to right, and the rock in the middle is your lens that split the stream. And in aqueous, if you rotate this image 90 degrees, then aqueous comes out of the ciliary body. Normally, a lot of it is jet in front of the rock or in front of your lens and goes through the pupil to the front. And if this rock or this lens becomes a bit more, move forward a millimeter or two, i.e. if you had a bit of a shallow anterior chamber, then potentially these aqueous jet, we're going to start jetting behind the rock or behind the lenses. And once it starts going behind, it's going to keep going behind and push the lens forward a bit more. And the lens go forward a bit more, the more aqueous is going to go behind. So I think this rock splitting the stream example is quite good. And often I think everything does start with a shallowing of the anterior chamber, either iatrogenically through surgery, intraoperatively or postoperatively, that move the lens forward. And then the aqueous in these funny eyes starting to not go in front of the lens, is starting to go behind the lens. And once it starts flowing behind, it keeps going and going and going and pushes everything forward. We all know the risk factors. And I think that when it comes to look at the risk factors, it's something that should be in everybody's mind. I have never really seen aqueous misdirection in someone who's a very high myope with a big eye. I'm sure it did happen, it's to somebody, but generally it is the smaller eyes. And the history is important. And sometimes as a surgeon, you sometimes forget to take a decent history. When you see a pressure of 18 or 20, you just think, I'm going to do this operation and get on with it. But history is important. If someone's had some history of aqueous misdirection in one eye, when it comes to the other eye, I don't think anybody should take it lightly and think you're going to get away with it, because it's nothing to do with you. It's all to do with the eye. So if they've had a history of it having it in one eye, you're going to be very careful about the other eye. Short eyes classically, so the shorter the axial length, the more wary you're going to be. And classically then will be the hyperope. So the high hyperope, when you're going to do something, either being just a cataract operation or filtration surgery, either being penetrating or non-penetrating for that matter, you're going to have to be very careful about it. So the same scenario that if you're operating on someone who's had previous angle closure, then that is a risk factor about aqueous misdirection. It happens after all sorts of things. I've seen spontaneous misdirection. I'm not so sure why it happened. I've certainly seen spontaneous misdirection in someone who's phakic with clear lens. But talking about surgical complication, more commonly, it's going to be after something that we've done to the patient. After phaco is a common thing in these short eyes, angle closure. So then when we are nowadays, maybe the ego is giving us the green light to take the clear lens out on just about every angle closure. And of course, that's not what the ego says. But when the clear lens extraction becoming more and more common, then we need to think carefully about our risk of misdirection. My very first clear lens as a first-year consultant was completely stung by a lady who developed misdirection afterwards, and she hated me ever since for it. So post-phaco is something you look out for, and I'll tell you about the signs to look out for. Post-trabeculectomy is quite classic in these angle closure eyes. If you're going to do a filtration operation, especially if they're phakic, you're going to be very, very careful about your filtration operation. You don't want them to drain very much. You're going to tie it really tight. You're going to work them down slowly. We've seen it post-tube, especially after a bar valve. When the bar valve opens at 7 weeks, 6 weeks, boom, they go low, and then you go into misdirection. And sometimes when you got a filtrating operation like a trap and a tube that's draining, you will find your shallow AC, you will find your flat anterior chamber, you'll find them in misdirection, but your pressure may not be very high because a lot of the aqueous is going out of your trap and out of your tube. We've had it after a PK for sure, and again, then you'll come back with a flat chamber, highish pressure. I do believe it's the shallowing of the anterior chamber that kicked things off. Like this rock in a stream phenomenon that I talked about. So you try very hard not to have a shallowing of the anterior chamber, either during the phaco in these eyes, during a post-trabeculectomy, tube, and so forth. Even PK, you try not to have a flat chamber during your phaco. You're trying to keep anterior chamber maintained at all time. So in these eyes that I think is a risk, short eyes, hyperope, I'm a bit against about an unguarded filtration operation. So to name them, I'm a little bit careful about something like a Zen or an InFocus. Even an Ahmed, and in my hand, sometimes they do go a bit low. Things that could just go low right at the start and you don't have much control. I'm very careful about those. And I'd rather do a trap and something, or even a tube that I can tie off tight. I can laser and open gradually, or like an eye watch where you something that you can have complete control of the flow. Unguarded filtration in a short eyes, you're asking for trouble. So how do you make a diagnosis? Often it's in the history. I think there's a few things that I've learned, and You've all known and seen this shallowing of anterior chamber, like this picture. And they're not just shallow centrally, they are shallow because you've got so much pressure behind pushing everything forward. So if they're phakic, they will almost be flat. So very, very shallow centrally, often with raised pressure because you've got this complete angle closure. But I think often we'll see a post-phaco, and I think the very important thing to remember, after phaco in a pseudophakic eye, they would be shallow, but they may not be flat. And you sometimes have really to have to look out for that shallowness in the anterior chamber. Sometimes they just don't look very pseudophakically deep. Sometimes it will be formed. There will be a formed AC, and then actually, but that is actually a little bit shallow. So if they're pseudophakic, you all know what pseudophakic eyes should look like. AC generally is very deep. And the lens and the iris pupil plane, often there is a gap. The IOL is about 1 millimeter or so behind the pupil plane. But if those two things are touching, then you start to think. And one of the biggest giveaway for me is that if you've done your biometry correctly, if you ended up getting a myopic surprise, you think you've got misdirection straight away. So if someone is a hyperope, you've done a phaco, and then afterwards you ended up -2, don't think your biometrist has got it wrong. You think and you look very hard for a misdirection. So you think your IOL might have moved forward, then you look carefully, why is it moved forward? Have you got retained viscoelastic in the back, which is pushing the IOL forward? You look for a back distension. But if there's no back distension and the PC and the IOL are both forward, often just by 1 millimeter or so, then you may have misdirection. Compared to the other eye, if they're pseudophakic, compared to other pseudophakic patients, they really should be deep if the IOL is a bit more forward. And a myopic surprise for me is a misdirection, and has proven otherwise. And one of the really interesting symptoms that I found is that patients are often unhappy with the vision. Even if you give them a -2 and they refract up to 6.6, they are unhappy with the quality of the vision. They feel like the vision is swirly. They often say that they feel like they're underwater. And then also the vision tends to alter. They find the focus go in and out, in and out. Sometimes they can read, and they may come back and say, I can read my newspaper unaided, fantastic. And that's actually is a problem. And if they're pseudophakic, you put a gonio on and the angles are narrow, then they may be in misdirection, because most pseudophakic patients should really be open unless they got PAS. And some of these pseudophakic eyes in a low-grade chronic misdirection, IOP can be normal. So just because the IOP is normal and you get a myopic surprise, it doesn't mean they are not in misdirection. So imaging is quite important. This is an eye that's in misdirection. So AC is deep. You will call it deep and formed, but look at the IOL. It's right up against the iris compared to the other eye. You see the difference here. And it's not huge, but that's enough to give you about a -2 myopic shift. And this eye is in misdirection. And this patient is unhappy with swirly vision. And pressure could be normal. Of course, if it's like this, then I think everybody can make that diagnosis. But it is the one before that often get missed. And then I've had scenario where someone's done a phaco and they ended up with -2 myopic surprise. They thought nothing of it. And the worst thing they did for the second eye, they aimed for a +2, thinking they're going to get them the myopic surprise, and they didn't. So they ended up with -2 in one eye and +2 in the other eye. And the patient's terribly unhappy because they missed a misdirection. So the treatment, for me, if there's some hypotony that's kicked it off, like an overdraining bleb, then that needs to be shut down. So I would shut my bleb down if it's a trap. I would directly suture the flap or pull a compression suture. If it's a tube, I'll tie it off. So I don't want a hypotony, which then stops me from forming my anterior chamber. You could try to reform your anterior chamber. Again, this rock in a stream business, if I can push the lens back enough, will it allow the aqueous to start streaming in front of it? Generally, you will find that you struggle to form the AC. When you try to refill it, there's a lot of posterior pressure. Atropinize them, there's always a standard. Atropinize 1% twice a day, warn them with the side effects. George Spaeth offered this advice. He says atropine is not enough. Give them phenylephrine 2.5%. This is the only time I would prescribe some phenylephrine. They want them maximally dilated. And ultimately, the treatment is that we want a communication between the anterior chamber and the posterior chamber, just like the diagram here. We need that corridor for the aqueous to start coming forward. So we need a communication. There's no two ways about it. So hence, you need a PI. So you can do a laser PI. And if you're lucky that behind the PI, the sonule is a bit weak, aqueous may start to flow forward. But often it wouldn't. But at least you do a PI to rule out any pupil block that may be there adding to it. The people describe a capsulotomy. You can yak the capsule. I have never managed to successfully reverse an aqueous misdirection with a capsulotomy. You can then aim the yak a little bit further back to yak the anterior hyaloid. I have never managed to reverse an aqueous misdirection doing that, but I'm sure some people have. Sometimes I do think maybe they were misdiagnosing it because they were retained viscoelastic with a back distension. Those will do well with a capsulotomy, not in true misdirection. Some people would then yak through an iridectomy like in a trap to try to break the sonule. But again, I think the yak can only go so far even with an argon. So for me, you need that communication. But if you have a misdirection coming to your clinic, flat chamber, and the pressure is 50 and 60, for me, the treatment is straightforward. I go straight for a cyclodiode laser. So the idea of the diode is the fact that A, you lower your pressure by shutting a bit of aqueous, but more importantly, there's a belief that that rotates the ciliary body. So for me, a diode is very useful in an acute malignant glaucoma with high pressure. You don't even have to do 360 degrees. You can just do 90 degrees or 180 degrees. I go for a standard destructive power, either 2000, 2000 or 1500, 1500, whichever you like. And for me, that has worked every time in bringing the pressure down and deepening the AC. Postoperatively, you'll see the AC deepen, you refract them straight away. A week later, you will see that the myopia reduce, and if the myopia increase, they are coming back into misdirection. So it's a good treatment. Sometimes it cures it, often it temporizes it. And there's been plenty published, and this is just one from the UK, from James Morgan, Phil Bloom, and Andy McNaught. So this is one of my patients. This is the patient that I was stung. 42-year-old, I did a clear lens extraction, ended up with a misdirection and myopia. I did a diode, and then the AC deepens tremendously afterwards. So it does work. But ultimately, I find that a good treatment is a vitreozonulohyaloidectomy. We don't need the VR surgeons. We are all anterior segment people. We can deal with this ourselves. So basically, we need that corridor between the anterior chamber and posterior chamber. So what we need is that we need a hole in the iris, we need a hole in the sonules, and we need to get rid of some of the vitreous. So basically, I have someone here who's pseudophakic in misdirection. We've got the right hand going in is just an irrigation. We've already got an iridectomy. So we normally would, that this patient's, we would normally shove an MVR blade straight through the cornea wound into posterior segment, and then we insert a cutter straight through the sonules behind the IOL until you can see it, and then you press your foot down. You do a little bit of core vitrectomy to remove the anterior hyaloid and a bit of core VT, and then you pull your cutter out and making sure that you carry on cutting as you pull it out. So then we're cutting some anterior hyaloid vitreous, cutting some sonules, and then you'll find that the AC will just deepen. Then you created this massive corridor between the front of the eye and the back of the eye, and misdirection will disappear. And that's all you really need. And I don't really believe you need to send it to VR for a 3-port vitrectomy. And even a 3-port vitrectomy, if you don't shave off the anterior hyaloid, then you won't necessarily cure the problem. You need this corridor, and you can create that quite easily with a vitreozonulohyaloidectomy that all of us can do reasonably straightforward. And that's all I want to talk about in aqueous misdirection, actually. Thank you very much.
Thank you, Leon. That was brilliant, as expected. I think we are going to go on with our schedule, and we'll keep questions and discussions to the end. So a real pleasure to introduce Ziad Khouer, who is like a younger brother to me, a brother that I've learned a lot from. He has been a leading figure in many aspects of glaucoma, but also specifically also in model and novel ways for cyclophotocoagulation and cyclophotomodulation. Ziad, go ahead, please. Ziad, we can't hear you.
Okay, can you hear me now?
Yes, we can.
Okay, thank you, Tariq, for the introduction. I'm going to talk about complications of cyclophotocoagulation. So those are my financial disclosures. So when it comes to glaucoma treatment, we have a wide variety, as you know, of therapeutic options, and usually we leave cyclodestructive procedures for end-stage refractory cases. And if you look at this figure, it's from a paper from Ramulu's team at Johns Hopkins. It was published recently in Ophthalmology. On the vertical axis, you have the total number of cyclodestructive procedures performed in the US under Medicare. And on the horizontal axis, you have the years from 1992 to 2012, basically. So you have 2 decades, and you have the impression that the numbers of cyclodestructive procedures have been increasing. Well, this is only because of the introduction of endocyclo. But if you look at the number of transscleral cyclophotocoagulations, the number are definitely decreasing. So this procedure is not that popular anymore. And this is mainly because it has a really bad reputation when it comes to the safety profile, with a very high complication rate, including hypotony, spikes, phthisis, chronic inflammation, and pain. And as you know, safety has become increasingly important when it comes to glaucoma management. And this is why a lot of effort has been done in the field of safety when it comes to cyclophotocoagulation. And I'm going to give a couple of tips in order to reduce the complication rate and improve the safety profile. So the most feared complication when it comes to cyclodestructive procedure is hypotony and hypotony-related complications. Studies have shown that the extent of IOP decrease is proportional to the number of laser burns. And not only the number of laser burns is important in that aspect, but also the total amount of energy delivered is also a risk factor for hypotony. In this paper from Brisbane that was published in 2013, you can see that the eyes that were treated that had hypotony had a higher amount of energy delivered during the laser treatment session. So my first tip is to use conservative treatment parameters. Don't go crazy when it comes to laser settings in order to avoid hypotony and phthisis. You can always retreat your patients. So do a session with conservative parameters, and then when you do another session, you can always modify your parameters. So another thing concerning hypotony is that when you look at the glaucoma subtypes, you have this paper from Shamira Pereira and his colleagues from Singapore. They looked into the risk factors for developing hypotony, and they identified neovascular glaucoma as a major risk factor for hypotony. So my second tip is related to that. You should always be careful in neovascular glaucoma. Those are very sick eyes. You never know how they're going to react after cyclophotocoagulation. I sometimes do only 180 degrees, and I explain to my patient, that they might need more than one session. It's better to be conservative in those eyes than to be sorry and then to be stuck in hypotony and phthisis. So we talked about the amount of energy, the total amount of energy in joules delivered during the session, but the number is not it's not everything. What's really important is how you deliver this energy. So you can deliver it slowly, like burning a candle, or you can deliver it abruptly, like a blast, like a stick of dynamite. So I really like, alternatives way of delivering energy lately. So I've been considering and using a lot the slow burn, slow coagulation technique, as well as the micropulse. So the slow burn or slow coagulation, for those who don't know, is the techniques that uses low laser power, 1.25 or 1.5 watts per shot, for a long duration for each burn burst. So you have the study from Bascom Palmer that was published recently that showed that the slow burn technique gives you good IOP reduction that is comparable to the standard parameter, but with much less inflammation. This is also another paper that was published from Hong Kong that showed that with this slow coagulation technique, you get a way better safety profile with very few complications compared to the standard parameter. Another alternative way in delivering laser energy is micropulse. So instead of delivering your laser energy in continuous mode, you just deliver them as bursts of laser. The rationale behind that is that with continuous wave, you have thermal built-up heat dissipation, but with micropulse, you have less heat dissipation, so a better safety profile with less complications. And the Robert Neuker has been publishing about that. As you can see, he treated human cadaveric eyes with a continuous wave diode, and you have an extensive coagulative necrosis, and this was not the case with the micropulse. So you have theoretically less tissue damage and it's better safety profile. This is a paper from Singapore from Paul Chu's team. They compared micropulse to the classical continuous wave. You can see that 90% of the micropulse patients in this paper were complication-free, and more than half of the patients with continuous mode got some sort of complication post-op. So we talked about hypotony. Let's not talk now about spikes. You know, we always underestimate the importance of and the danger of spikes after cyclophotocoagulation. We only focus on hypotony. Spikes do occur, and they occur in approximately 1/3 of the patient, 34% of the patients, according to this study here. And they identify, you know, one of the major risk factor is that they occur more frequently in patients who had a lot of POPs during the treatment. So one should not always look for this magic mystical POP when doing a cyclophotocoagulation. And I'm usually quite aggressive with spike prophylaxis, especially in patients who have, you know, really compromised visual fields, and I always check the pressure 1 hour and 3 hours out after the procedure to identify those dangerous spikes in patients with really compromised visual potential. So let's talk now about limbal anatomy. A really important point when it comes to cyclophotocoagulation is to know that the ciliary body is not a circular anatomical landmark, because the distance from the ciliary body to the limbus is variable from one quadrant to another, as you can see here in this table. So translip illumination is very important, and you should always use this tool, especially in eyes where you might have an atypical limbal anatomy, like in congenital glaucoma or in myopic eyes. So it's always good to identify where the ciliary body is. It's not standard, it's not circular, and this allows you to be able, you know, to deliver laser energy to the correct anatomical landmark, increase the efficacy of your treatment session, and get a better safety profile. Another tip, other than transillumination, is probe position. Probe position is very important during the treatment. Whether you're doing continuous wave cyclophotocoagulation or micropulse, sometimes you can end up with mid-dilated, fixed pupil, atonic pupil, and this is a known complication for cyclophotocoagulation. This is from Bob Rich's paper. You can see the untreated eye has a pupil that is reactive to light, as you can see here, but the eye that had a cyclophotocoagulation has an atonic pupil that is not reactive to light. This is another extreme cases where you have pupil distortion after cyclophotocoagulation, and you can see here an iris defect that is probably due to the fact that the laser energy was delivered too close to the iris root, inducing laser damage. So probe orientation is very important to be able to deliver, you know, laser energy to the correct tissues, especially, you know, when you're doing micropulse, but also probe position is key, especially for beginners. We always have the tendency to place the probe way too anteriorly, and this can deliver, you know, laser energy at the level of iris root, increasing the rate of inflammation and pupil related complication. Another tip is related to treatment technique. You know, everyone thinks that this is laser, this is not surgery, so treatment technique is not very important. Well, treatment technique is really important and is unfortunately underrated. The study here from MGH shows that when you're delivering laser in a transscleral fashion, part of the laser energy is reflected, part is transmitted, and part is absorbed. And just by changing the amount of pressure that you're applying with your probe, you can significantly improve the efficacy of laser transmission to the tissue. So the amount of pressure that you're applying to the tissues is extremely important. So treatment technique is very important. Good coupling to the tissues is also something that is extremely important. You should use a coupling agent to have really good contacts, because studies have shown that if you have poor contact, a lot of energy will be reflected back, diffracted. And when you have good contact, good coupling with a good coupling agent, most of your energy will be delivered to the tissue, and this will increase the efficacy of your treatment. I'm going to end up here with the last tip of the day. Always remember probe care. We have the tendency, especially in developing countries, to reuse our probes to be able to deliver affordable care to our patients because of the financial situations in our country. And sometimes by reusing the probes, studies have shown, you know, there's a paper in IOVS from Robert Neuker doing specular microscopy on reused G probes. You can have cracks at the level of the probe tip. Sometimes you can have fibers that are stuck when you clean the probe. And when this thing happens, you can deliver a lot of heat, a lot of energy on the ocular surface. In extreme cases, like this case here from India, you can end up having scleral perforation and bleb formation. You can see here the scleral perforation and the bleb that formed following scleral perforation. This is another case of scleral perforation and conjunctival burns. So always take good care of your probe and probe tip. Apply generous coupling agents like a transparent gel, carboxymethyl cellulose, for example, to avoid those complications. This is a patient of ours. You can see the bluish hue that indicates scleral thinning, or I wouldn't say scleral melting, scleral thinning in this case, probably because there was a lot of energy that was absorbed by the sclera in this case. So those were basically my tips to reduce the rate of complication in cyclophotocoagulation. Treatment technique is very important, and I think in the future, by improving the treatment technique, but also the way we deliver laser energy to the tissue by using slow burn and micropulse, we will be able to use cyclophotocoagulation earlier on in the course of the disease, and even some patient with relatively good visual acuity can benefit from it with a good safety profile. Thank you very much.
Thank you very much, Ziad. That was really, really interesting. I think we move on to a great humanitarian, a great innovator, Rick Sponzel, San Antonio, Texas. Rick is one of my oldest and closest friends. Rick, before I pass on the mic to you, I just want to make sure that you will vote well.
Oh, it's too bad I didn't put one of my favorite slides in of our Biden poster. You know, the one that I sent you a picture was stolen off my gate. So I bought a bigger and better one, and I put it in with bolts. And it has an alarm that goes off if you get close. Anyway, it's yeah, we are praying for return to sanity sometime soon. That would be nice. You can add your prayers, please. It's hard here. It's very, very bad. I don't like it. But meanwhile, let's talk about nice things. I need to share my screen, and I need to select the slideshow. But it is offering me a funny file. It's not letting me have my desktop. Does anyone want to offer me some suggestions? We had it on the screen earlier.
I guess you need to close all the other windows and then share your screen.
Okay,
I think that is what this is how it should work.
Yeah, I'm still, I'll try it again. It says share screen, and it's now giving me different from in our preparation. I'm not finding my.
You open your PowerPoint now?
I can open PowerPoint, but it doesn't give me the one I want. No.
This one.
Is that your screen?
Yes.
I can find there. I have my
I think you need
that's
to.
my screen. Okay, I think we're ready. Will this work? Can you see my screen?
Not
Yeah,
yet.
share it again.
Let's start.
Share it one more time.
I'm seeing this program, but you are not, I guess. Okay.
No.
Okay. We'll escape. We'll try again. It should be on my desktop, and I apologize because we had it working perfectly an hour beforehand. I say share screen, desktop. Here we go. Now this should work. Sorry about that unfortunate delay, but is that working well?
Yeah,
Yes.
it is.
Okay, thank you. Sorry about the problem. Okay, so now we can begin. I've been asked to talk about failed tubes. And in this case, we're talking about failed tubes like Bearvalt's, Maltino's, and Ahmed tubes, not the little ones. Now, we'll not only be dealing with our own post-op problems, but throughout our careers, we're frequently asked to rescue failing surgical patients referred by other very good eye surgeons, some of whom we've trained. And our job is to calmly and promptly fix the problem, averting disaster while allowing the patient to retain faith in their referring physician. I want to, you never were there when they had their problem, and you must remember that our job is to instill faith in the patient with their doctor. This means really fixing the problem and not just doing another procedure that wastes virgin tissue and effectively labels the prior surgeon's work a failure. And this is a correct thing as good colleagues, and also it's a good business principle because patients like it when you can explain all the nice things their prior doctor did that were worthwhile and that you only had to fix a few little things to make it work again. Now, I gave a talk on a whole lot of the sort of things that we're covering in this session at one of the excellent ISGS Geneva workshops, the masterclass. And so I'm only going to talk to you about this little bit about fibrotic tube shunt encapsulation, viscoelastic flush versus posterior shunt, okay? And one of our most respected colleagues, Mark Sherwood, gave a nice talk at the ISGS Congress in Montreal a while back about the study they had done just previous to that in Florida. And they looked at 51 eyes of 47 patients with inadequate pressure control on medications after either a double plate Maltino or Bearvelt implants since 1986. And they found that they were doing a second tube in 15 of the eyes, and they did a YAG or diode cyclophotocoagulation treatment in 31 of those eyes. That's a quite large proportion. And this is his graph showing the number of people that needed to have something done because the tube just wasn't behaving properly. Now, we're all familiar with this fibrotic, early pre-cross-linking problem that occurs after about 3 months from the time of implantation. And then people often try to ride out this ocular hypertensive phase and use drops and hope that it goes away. I don't do that, nor do I do anything of the kind with ones that have been failed for years that get sent to me maybe 2 or 3 years after they've had any prior good pressure control, oftentimes on multiple medications with a large bleb. Instead, I do this thing, which I hope many of you will try. And this is the practical thing that's immediately available to all of you and very inexpensive. Can be done in the clinic if you have a busy situation, but it's a reimbursable major procedure that you should do in the operating room if you get a chance. And it's very simple, but it needs to be done in the right way. So I'm going to try to explain this well. This is a paper that you can all get from 2015 describing the technique. But you go into the anterior chamber with a 25 gauge needle, as shown in the upper left. And you align it with the tube. And ideally, you have some pilocarpy, you make the pupil small. This patient's pupil wouldn't go down, but that doesn't matter. You then want to, but ideally, you avoid any pathway that would go over the pupil, because when you do this, you're going to get a Venturi effect. Will often suck the anterior chamber empty and give you a shallow chamber. So you don't want to be having to withdraw your instruments over the actual anterior capsule. You might create a cataract. I've never done it, but I promise you it could easily happen if you do it carelessly. Now, you just get viscoelastic, and ideally, you do it with a 27 gauge cannula that comes with the viscoelastic. Occasionally, the tube lumens are just too small to get into it, and you maybe go in first with a 30 gauge cannula, and then follow it with a 27 if you can, because the 27 fits in the lumen of standard tube shunts perfectly. It doesn't seem to. It seems like you have to wiggle it into something that's too small. But if you just use a little finesse with your fingertips as you go in, you can insinuate the cannula into the lumen of the tube. Ideally, you get it 3 or 4 millimeters up, almost to the limbus. Be cautious that you spin it and don't just push your tube out into a sort of pseudo blab and then have to rescue your tube. That's never happened to me that I can remember, but I've gotten close, where it's scary how close you get the tube. So you have to, you can even push a little viscoelastic and wiggle it a little bit, so this will go all the way up. You get a hermetic seal. A 30 gauge does not give you a hermetic seal. It gives you, but what it can do is you can advance it all the way up to the bileaflet plate of an Ahmed. So if that thing is stuck with protein, you can pop that open with a 30 by pushing it way up, but you got to be careful not to make a hole in the tube. But all you do then is empty this 0.55 ml of viscoelastic rapidly as a bolus, and you pop the bleb. Now, you all know you could do the same thing with balanced salt solution, and it would make the bleb big, but it won't work long term, because all that's going to do is make little sinuous openings that will immediately reseal. The viscoelastic bolus will pop open the base of this encapsulated fibrotic bleb in many locations in a 3-dimensional sort of manner, opening the base and creating a big bleb rapidly that will not reseal, and it will stay for the long term. So here's 43 consecutive people who are treated with this simple technique. They started with a main baseline IOP of 26, and they were on multiple medications, some of them, others were on few. Mean 2-year post-op, the pressure was 15. So this can convert a failure. Instead of wasting another quadrant, putting in another tube shunt that's bound to do the same thing, you rescue the existing one. And that makes everybody happy. The patient's very happy that their old operation still works. I've saved many other surgeons the embarrassment of a failure by simply doing this simple thing. And they could do it themselves, but they keep sending me their patients for some reason. But this is an extraordinarily significant long-term control of intraocular pressure with no increased medication required. So that's the simple thing I'm offering you that everybody can do. It costs you nothing. You can bill nicely for it. You can do it as often as you want. I would do it even at the 3-month phase if you have something that's frustrating you, but you can do it on something that's been sitting there for 10 years. It'll still work in many patients. So I always try that first, but I still had some patients who had such bad blebs that were so encapsulated that they simply wouldn't respond to even that treatment. And so I had to come up with a new solution. And this is now something that is patented and available soon to those of you who are interested. This is the way we started this exciting new area of working with retrobulbar tube shunts. So here we see opening up over the encapsulated bleb. Okay. And I'm going to find the edge of the shunt posteriorly. And now I'm going to take this special device that's been made for us by the New World Medical, and subsequently HAL has made something like this that's available. And you can put some viscoelastic and make sure you get all the bubbles out of that thing. It's a huge tube that's the same size as the scleral buckle tubing that's used for cutting little rings to make a scleral buckle. This is now sutured in position with some Proline. This is a handmade one. And I'm putting the anterior component, which has large fenestrations in this large diameter tube, into the back of the bleb where I opened up at the rim of the encapsulated bleb. And then I have the ability to open up the retrobulbar space here with a muscle hook. And I'm going to grasp this posterior polyfenestrated component, which is full of viscoelastic, and pop it back into the retrobulbar fat pad. Now that that's firmly in position, I can put a couple little stitches in to secure this against the bleb. You can easily suture into the rigid bleb. And now we have this hermetic seal between the bleb and the retrobulbar space. So now the existing encapsulated bleb is really a cistern that's inert. And as you do the surgery, you'll see the inner lining of the bleb is almost like hyaline cartilage in the knee or something. I mean, it's just shiny, rock hard stuff. There's no way capillaries could ever receive aqueous humor through such a rigid membrane. But it is a beautiful receptacle and an intermediate cistern for the aqueous humor between the anterior chamber and the retrobulbar space. Now you might be saying, well, what the heck is the point of putting aqueous humor in the retrobulbar space? It's hydrophobic. So here you see the original tube and in nice position. And this pressure was 12, 1 month post-op on this guy who had a very high pressure beforehand. So we've now published this paper, was from 2018, and another one that's just about to come out, a longer term follow-up, looking at the efficacy of novel retrobulbar extension shunts to rescue eyes with fibrotic encapsulated blebs and uncontrolled ocular hypertension. So remember, again, you put in a state suture, you make an incision into the back of the bleb, you insert the tube in, as we showed. This is the one that where I made the holes with a Kelly punch in a regular piece of retinal tubing. This is the first way we did this. We sutured the tube to the bleb base, expose the subtenon space with the muscle hook, and shoot that thing into the back of the eye. And then you just close up with some Vicryl 8.0 in the deep layer and as well in the conjunctiva. And here are the long-term pressure responses out over 5 years, showing the spectacular long-term control in these otherwise failed. Now remember, these are total failures. And most people, I've had patients come in with stuff in every single quadrant. And you know, it's not necessary. You can use that original tube and that original reservoir and tell everyone what a good job the first doctor did and make it work even better. In fact, as well as you might expect from an antimetabolite filtering procedure. How can this be? Well, what happens is the redirected aqueous humor forms lymphatic-like microcannulae between the hydrophobic retrobulbar cells, allowing fluid to be reabsorbed continuously into the hydrophilic orbital periosteum. And these are some rabbit experimental things that we did with Dr. Ayala down in New Orleans and his team of fellows, where we put a lot of these into animals to see what happens and sacrifice them. And for a start, the pressure control in the eyes that had this sort of front to back tube shunt arrangement remained below the normal pressure throughout the 3-month phase, whereas the ones that we the fellow eyes of the same rabbits that we put standard tube shunts in fibrosed and the pressures rose above the ambient pressure that at the beginning of these operations. So we know we're getting great pressure control against a very strong tendency for fibrosis in animals like rabbits. And the wonderful thing is that there is no fibrosis, but there's no room for fibroblasts to proliferate in the retrobulbar fat pad. But between those cells, there is a little hydrophilic space through which the aqueous humor can form new microcanaliculi that tend to be radiating out and directed towards the periosteum of the orbit for continuous resorption. So we look at these 5-year levels. You can look at all this nice results that we had really extremely good pressure control, highly probable all the way out. And the only reason this statistics is lower, we just have a smaller n at that point, with progressive entry into the study. And we had very little or no attrition in that study. So this is the business end of the one that's been made now in Europe. And you can learn more about it. The next paper should be coming out, we hope soon, in a peer-reviewed journal that you're all familiar with. So to remind you again, the difference between a standard shunt that finishes on the eyeball and what is now going to be a new phase of the front to back, no bleb at all, primary insertion, A to B shunts, anterior to back. This is where it ends up with these little canaliculi ending up in the fat pad. So it's much longer. It takes the fluid way far away from the eyeball itself. And so you don't have to worry about having a bleb that you are concerned with. You can use the same technique for insertion. This tube diameter is the same as an Ahmed. You can put pseudoplast on or not if you like. You can put them in superior or inferior. And because it has no bleb, it's relatively safe and lower risk for having endophthalmitis and other problems if you do happen to put them in inferiorly. So I'm excited to tell you about this new thing that's coming out, and all the companies are working on their various marketing and patents and stuff. But sooner or later, those of you who are interested would like to do studies. I'm sure we can get compassionate use to any of you who might be listening. And final note, please stay safe. We need to keep you all around to treat patients with eye disease and also to love your families and vote for good people for office. Thank you. I'm done.
Thank you, Rick. Thank you. That was excellent and exceptional. I am moving on to a man who needs no introduction, my compatriot Ahmed Al-Karmouti, who's going to speak to us about hypotony, I believe, and managing that. Ahmed, please.
Thank you, Tariq. I would like to thank you for your kind invitation. I would like to thank Al-Watany Eye Hospital. It's my second home, actually, or my home when I go to Cairo. So today I will talk about hypotony. We know that usually, as generals say, that pressure of 40 better than 4. This is only because both of them can cause loss of vision, but hypotony can quickly lose, you can quickly lose the eye in no time. And I know lots of surgeons, like myself, wouldn't tolerate hypotony and would rather have high pressure than low pressure. So hypotony, usually defined as pressure of, as a numerical definition of pressure of 5 or less, but actually it should be physiological definition, because if the pressure is 5 and there is vision 6/6, no hypotony, maculopathy, no choroidals, we shouldn't call this hypotony. It's just a number. The main important thing I just want to point out about the pathogenesis is hypotony can cause inflammation, and inflammation can cause as well hypotony. But the tip is, if you want to cut down the steroids, cut it, but don't stop it altogether. Because as I said, hypotony with the breakdown of the blood aqueous barrier can make it a bit difficult if you stop the steroids altogether. Signs, I'll go through it quickly. Pressure, low pressure, flat AC, shallow AC, corneal edema and decompensation. That could be a thing that you cannot detect it early because of the pressure of 3 and 4, no hypotony, no choroidals, but the cornea will get steamy by time. The fold on Bowman's membrane folds could tell you as well that the eye cannot take this low pressure. Synetia formation because of adhesion, wound leak, and corneal astigmatism can also be there. Accelerated cataract formation, which is important because some surgeon would and patient as well are puzzled why there is a cataract happening quickly. That's the hypotony. It's not just the lenticulocorneal touch. Hypotony maculopathy, we have like a 4 weeks window, should not leave it longer than that. If it's not sorted itself out within 3-4 weeks, you have to go back and fix it. Optic disc swelling and vascular engorgement as well. The other thing is we have to put things in context. So if the pressure is too low with choroidals after trabeculectomy and there is no leak, you have to find or look for drainage, good drainage. I was called in, I was on call, I was called to fix hypotony after trabe, and the bleb was completely flat. So this was overreaction or oversensitivity of the ciliary body to the dorsal lamine. And of course, otherwise, if you didn't pick up this, you would have gone and fixed and put stitch on the trap. Hyperopic shift and reduced axial length. If the patient had biometry before the operation, I think probably you need to redo the biometry because the IOL calculation would vary. Some cells and flare there, and you shouldn't be confused with endophthalmitis. Of course, choroidal effusion or hemorrhage can occur as accumulation of fluid in this potential space. So I'll go about for the different causes of hypotony after different glaucoma surgery. And I'll start with the trabe, which is the most common, I would say, till now after the tube, or even just maybe a bit more than the tube, is the trabeculectomy wound leak. Usually, as a general rule, early leak is better than late leak. And this has to be either leak from the limbus or a leak posterior to the limbus. If the leak is at the limbus and it's small and not that brisk, I think a bandage contact lens is worth trying with cutting down of steroids, but don't stop the steroids altogether. And it can sort itself out. Keeping in mind that the limbal leak doesn't have sticking out tenon because the conj will not heal. If the leak is brisk and you think it's not going to sort itself out, then probably you need to go back and fix it. This is a technique which usually Norbert Pfeiffer used for all of his cases. If you can see that he has a corneal scratch, then he take a continuous suturing from one end to the other with interlocking suture in between to make sure that he has good closure in every single patient. I think it's a bit too much, but I think that's a good technique if you want to take back the patient and fix some leak. Again, if it's posterior to the limbus, as I said, I think you probably need to completely get rid of this area by cutting. Here it is, the leak here. You have to cut all this area with a safety margin because this is like a fistula now. Putting a stitch, this will not fix the problem. You have to take the whole conj out and try, if needed, to take a stitch on the flap and fix it completely. If you think there is no much of a flow, then you can suture it, but you have to take the conj and the tenon out. And when you close the conj, you have to make sure that you search for tenon, otherwise it will just disseminate and it will open again. If it's over filtering, of course, we take all the precaution like a bit thickish flap in uveics, extra suture, but sometimes it can happen. And as I said, if it's early, it can be well tolerated and it can sort itself out, adding some cycloplegic and reformation of AC. But sometimes it's a mistake of the surgeon. In post-op, some surgeons are a bit worried about hypotony. So they take one corner of the stitch on one side to avoid hypotony, and they keep the middle releasable to the end or to the last. This is the last one to be put on table and the first one to be taken out. If you left it, well, and this is the killing suture or the controlling stitch for your flow, and you left it to the last because you are worried, this can cause actually unexpected hypotony because there is no guarding a side suture. To buy some time, we can inject some Provisc, and this is not the definite thing, but it can sort out short-term hypotony and help the eye to be supported during this time until it sorts itself out. So we do it in clinic. You don't need to take it back to theater. This is a video from Keith Barton, who does everything on slit lamp except the surgeries. But he, just to show you that it's not that difficult, and even I've done it in very flat iridocorneal touch, fake cakes, and even with a very small microcornea and small eyes on slit lamp. Sometimes you have to go back and fix it. So this is a really over-filtering there because the gap of the flap, there was no tight suture, and you can see the fashion of the flap was not that very good. Some techniques are used like blood patch or inject subconscious blood, but I think this you need to fill up the AC completely with blood to do the trick. I'm not sure about these techniques like laser, cryo, but I have seen injection of gas in pseudophakics in late hypotony due to over draining bleb, and it did the trick, but I only saw it once. I didn't do it myself. Again, the revision of the bleb will be probably the mainstay and the best thing to fix the problem rather than wishful thinking. Sometimes it's not like extra stitch. So this is a flap that had probably like 6 or 7 or 8 stitches, but this will not sort itself out, and extra stitch will not fix it. So be prepared that 15-minute job can take up to an hour. So the last one and this one with the bad fashioning of the flap, probably you need to patch it. You put a stitch as much as you can, but again, probably will need a flap. You can put this, this is a Cheetah. If you have a cornea, you can use it. Sclera, you can use it. But please don't go and take the patient twice just to fix one problem. It's either you fix it from the first time, try as much as you can, of course. Diode laser is a very quick and safe procedure, but has lots of problems like Dr. Ziad beautifully presented. The only thing is we have to be careful if the patient had previous diodes many times. You don't want to do the last one that will kill the eye. If it is like uveitic, and I hope that we deal with uveitic glaucoma according to the cause of uveitis and don't deal with uveitic glaucoma as a general the same. So GIA, VKH, and BEST, I think it's better to avoid the diode. Non-specific anti-uveitis, probably you can go ahead. Infectious uveitis as well, you can still do diode. Of course, if there is a trauma and the pressure is still 50, doesn't want to respond, you can do diode. Malposition IOL and the patient or the vision cannot allow you to go back and fix the malposition IOL. You can buy some time with the diode. Most of the time, steroids will pick up the pressure, but in very few cases you will find you will lose it no matter what you put. Shunt implant. Now there's more and more use of the tube operation, Ahmed Barbel tube, and the twin of Barbel tube, which is the ADI from Orolab, it's an Indian tube. So usually the Ahmed valve ABC, AVB study showed it's safer because it doesn't bring the pressure too low like the Barbel tube, but you have to be sure that you don't touch this box while implanting it. Otherwise, you will have hypotony, and you can easily blame the company that it's bad manufacturing. Well, you can be part of the problem. Shunt implant, I think in the States, most of the surgeon will just ligate. And here in UK, we stent and ligate. So sometimes you have the problem after removal of the stent, then you go into hypotony. You can easily put back the supramid, but the thing you should be doing is you have on the operating paper, you have to document where is the supramid, the tube or the tube plate from the limbus, so you can measure exactly how much you can put inside the tube, because you don't want it sticking outside the tube and rubbing against the cornea and cause corneal decompensation. So you have to put it back exact length where it is not sticking out. So the measurement on the operative notes here are very important to be documented. The only thing with the ADI that it's a bit bigger, and the supramid will be the best option. The ethylone 6O might not be enough. So 6O ethylone might be okay for the barbel, but I think it will not do the job if you stick it through the AC for the ADI. Sometimes you can go back like Dr. William showed, you can open the plate and feed the stent through the barbel tube and the plate at the back, and either with or without ligation according to the pressure and how bad is the hypotony. Until you can as well judge the flow on table and make sure that you make the good decision. You don't want it too tight, otherwise you go back to square one. MIGs have been used more and more over the last 4 or 5 years. There has been some cases of hypotony, but generally it is safe. But as Leon mentioned, yeah, there is an early hypotony and sometimes flat AC choroidal with the Zen, with the in focus, but most of the cases they sort itself out, and very few number of cases they will need to be either taken out or to be fixed and either blocked. So there was one in focus. Keith Barton put like 9-O-proline in it, and not fully in it, but just a little bit, and this was enough. There was one side pass, again Keith Barton put a proline suture in it to fix the hypotony. Then you cannot pass anything through it actually, but it's just make sure that you don't have brisk flow on table. Again, at the end, this hypotony is probably better to be looked at as a physiological definition rather than numerical. You have to be careful if you're thinking of stopping the steroids. I think you should have some on board. If you can deal with hypotony, you can save the eye, and please, if you can't, you can easily lose the eye if you don't know what you're doing. Thank you very much, actually.
This was very comprehensive. Thank you very much, Ahmed. We move on to Dr. Omar Magdi, who is a glaucoma specialist from the Watany Eye Hospital and a bright star in the Egyptian glaucoma skies. Omar, please. Can you unmute, please?
Oh, thank you, Dr. Tariq. I'm going to share my screen now. Okay, good evening all. My talk today is about Monsters, Inc. We as physicians face our fair share of challenges. From time to time, things won't go as planned, and we will have to handle unexpected nightmares. The question is, how do I deal with these challenges when they arise? Like this case. A 40-year-old lady presented to the clinic complaining of diminution of vision in the right eye. She was diagnosed with juvenile glaucoma 31 years ago. Previous history of cataract surgery in the right eye 6 years ago, followed by subscleral trabeculectomy 1 year later. Less than 2 years ago, she had a vitrectomy surgery in the same eye with a gas tamponade. Left eye was lost due to untreated retinal detachment 6 years ago. She was on maximum topical treatment and Diamox tab 4 times per day. There was no history for systemic conditions. On examination, her best corrected visual acuity was 0.8 in the right, PL for projection in the left. The pupil showed sluggish reaction in both eyes. The anterior segment showed pseudophakia and flat bleb in the right, diffuse corneal opacity in the left with no view for the posterior segment in the left eye. The left eye showed the right eye showed cup disc ratio of 0.9 with severe myopic degeneration and IOP of 32 millimeter Hg. This is her visual field showing severe field damage. And this is the OCT optic nerve head and ganglion cell complex showing reduced retinal nerve fiber layer thickness and ganglion cell complex. So the decision was to go for urgent Ahmed valve implantation in the right eye, and the surgery was uneventful. In the first day postoperatively, best corrected visual acuity was 0.1. AC was formed and clear, tube in place completely covered with no leakage. Intraocular pressure was 14 millimeter Hg with minimal choroidals inferiorly seen within a narrow pupil. But that was only the calm before the storm. The patient experienced severe pain immediately after examination, and she returned back to the slit lamp. We saw a total hyphema. Vision dropped to hand motion, poor projection, and we ordered an ultrasound which showed a suprachoroidal hemorrhage. So, what is the mechanism of suprachoroidal hemorrhage? There is acute ocular hypotony, uncontrolled systemic cardiovascular risk factors like hypertension, fragile choroidal vasculature, and elevated scleral and/or choroidal vascular pressure. What are the risk factors for suprachoroidal hemorrhage? There are some systemic risk factors like the use of anticoagulants, advanced age, uncontrolled hypertension, atherosclerosis, diabetes, and Valsalva type maneuvers like postoperative emesis. Ocular risk factors like acute drop of IOP, axial myopia, aphakia and pseudophakia, and history of suprachoroidal hemorrhage in a fellow eye. How to manage a case of suprachoroidal hemorrhage? First thing, we should try medical treatment in the form of topical and systemic steroids, cycloplegics, ocular antihypertensives, and oral analgesics, all for 7 to 14 days. These are for liquefaction of the blood clots. Then there is a surgical management. We can do a conjunctival periotomy, a 2 millimeter to 3 millimeter radial full thickness sclerotomy, 4 millimeter posterior to the limbus in the quadrant of the most bolus is done to drain the blood. Also, another maneuver is to go for pars plana vitrectomy with high infusion pressure and injection of perfluorocarbon liquid into the vitreous cavity, assisted with which assist in the mechanical displacement of the blood and facilitate the drainage through the previously created sclerostomies. Back to our nightmare. Medical treatment was initiated to this patient for 2 weeks with minimal improvement. A vitrectomy with drainage of the suprachoroidal hemorrhage was performed. A best corrected visual acuity hopefully returned to 0.5. Retina and choroid were in place, and IOP was 15 millimeter Hg. So remember, it's not what happened to you that is the problem. It's how you handle the nightmare so that you are able to better overcome future monsters. Thank you all.
Thank you, Omar. That was nobody can envy your position in something like that. I think if you may allow me, I'll give my talk, and it is brief.
I wasn't this type of life, she saved my life.
It is about blebs and patients, and this is one of my patients who has one single eye, and we did a deep sclerectomy for him. But let's first remember what is a bleb. a bleb as is defined in a dictionary as a small blister on a skin. It's a small bubble. It's a rounded outgrowth on a surface of a cell. All sound like a negative connotation to the word. And, you know, remember that a bleb is actually sort of an insult on the normal, beautiful topography of a globe. So a globe is beautifully formed and constructed, and we come in as surgeons and create those horrific things, calling them a bleb, and look at them in awe and in sort of, you know, self-admiring ourselves in our destructive measures on the ocular surface. Well, of course, sometimes we get those kinds of blebs, a shallow bleb that is diffuse, that is not prominent. You can see it beautifully vascularized. It's not atrophic and is associated with a low intraocular pressure. Indeed, an interesting bleb, but this is not what we always get. We aim at a sort of a posterior bleb. More posterior drainage that we have is always associated with better results and better longevity of those blebs compared to something that is very limbal and that is prominent and atrophic. Unfortunately, not all blebs go like that. And to the best of our knowledge and to the best of our, and with all the experience that we have, we sometimes meet such blebs that are, you know, encroaching on corneas, blebs that are associated with Dellens, and thin blebs that can be precursor to massive problems. These kinds of blebs we are meeting more and more as we are liberally using mitomycin to every moving patient in the operating theater that is complaining of glaucoma. And when you see a bleb like that is totally avascular and totally thin, remember that there is a potential for catastrophe. Now, blebs sometimes need needlings, and needlings are a very violent well, you're using a lot of your imagination because needling is something that is done blindly. You're not seeing it, but it is. This video has been chosen just to show you that it is really an aggressive maneuver on the eye. And though we are again doing needlings more and more, and I know some of my brilliant colleagues who can take a patient to 7 needlings before he says or gives up on a bleb. And those blebs are very tricky because you get a patient with a bit of a hypotony, just like Ahmed showed you, and you look at the bleb, there's a bit of a wetness, you know, a bit of leaking. But if you are tenacious enough and you look very carefully on these blebs, you might be surprised with other areas that are profusely leaking, as you can see here. And as aqueous can traverse the bleb wall and get out, it is absolutely comprehensible that microbes can also traverse in to the blebs and finish up with a sort of an endophthalmitis. This is the same bleb that you've seen here after being completely reconstructed. Luckily, with this, I got away with it. I totally excised the bleb and created a new bleb, and we ended up controlling the pressure despite having to excise the leaking bleb completely. Getting some sort of a vascularization in a bleb is important. Otherwise, it can be doomed into something like an endophthalmitis. So I think the most important thing about managing bleb-related complications are to identify, first of all, that blebs are generally not a good thing. And this is important to remember. And remember also that blebs can be associated with dysesthesia, so discomfort. I have a patient of mine that I remember quite clearly that spoke about the sound of her bleb. And, you know, true enough, when you listen carefully with the bleb to the bleb as the lids are moving on it, I mean, I wouldn't go all the way to say that blebs were speaking to me, so I'm not a bleb whisperer, but blebs can make sounds, and these sounds can actually, you know, to a big extent, be very troublesome and annoying to the patient. So nowadays, this is what we have in terms of all those types of procedures that are available. And as we look at them, we have to wonder if there is some light at the end of the tunnel. So MIGS, of course, we have been promised a lot with blebless surgery, angle surgery, putting, you know, stents and putting stents in the trabeculum, or putting stents in the suprachoroidal space, or opening Schlemm's canal with one way or another. All those are beautifully blebless surgeries, but none of them so far has been able to dethrone our conventional surgeries in terms of trabeculectomies, deep sclerectomies, or tubes. One thing that I find interesting when it comes to blebs and the new devices is what I call a hybrid bleb. Here you can see an arrow, or an arrow is a very tiny tube that is inserted ab external, as you can see here. And the interesting thing about it is that filtration is not happening at the limbal region, but it's happening quite posteriorly, about 8-9 millimeters from the limbus, which provides these kinds of blebs. So these are, you know, filtration is very posterior, and it is diffuse, and it is relatively shallow. I have very few patients suffering from those blebs. They actually, if you put one of those in one eye, compare it with a conventional bleb of a trabeculectomy or even a deep sclerectomy, patients usually feel much better with those kinds of blebs. So those hybrid blebs, are they the way to go? Only time will tell. Jury is still out, but it is not always the answer. It's not. I'm not sure that they come as the holy grail of glaucoma. This is one of those implants. This is a Zen implant, and the patient came to me basically with the implant totally eroded. Let me show you that again. And what we did basically was taking a tying forceps in front of the slit lamp and picking it out. So nothing that complicated. But still, this specific patient continued to have a hypotony. His pressure was as low as 2 to 3 millimeters of mercury. So you look at gonioscopic evaluation and you find a ciliocoroidal cleft. So those new devices come with new sets of complications. You cannot just think that under peer pressure, as the guy next door is doing this operation, you have to jump on the bandwagon and do the same kind of procedures. And the worst thing ever is to be jumping from one procedure to another, not gaining enough experience with one procedure before jumping into another. So to summarize, blebs are bad. If we can dispense with blebs, it will be much better. If we can get better blebs, it will be even better. Bad blebs have to be identified early on before they cause damage and before they end up with hypotonies, with blebitis, and with endophthalmitis. With that, I thank you very much for your attention. I hope that was interesting. I will stop sharing my screen, and I will thank all my panelists and my co-speakers for tonight. And I think we still have a few minutes to take some questions. We'll answer some of the questions. So if any of our participants, we have more than 200 people on, if anybody is interested, please ask your questions. I got one question for Leon. Leon, there have been reports about malignant glaucomas happening in after express shunts done in narrow angle glaucomas. Have you experienced or read something about that? I mean, express is still popular in some places around the world, and personally, I kind of abandoned them, but there are still people doing them, and I'm all the time worried about reports that I'm hearing about malignant glaucomas in narrow angles with expresses. So do you have some words of wisdom related to that?
Well, I don't think there's anything special, Tarek.
Can you unmute, please?
I have. Can you hear me?
Yeah.
Yeah.
I still can't hear you.
Oh, really?
I still can't hear you.
Can you hear me?
Maybe I have a problem. Hold on. Yes. Sorry. Now I can hear you.
Yeah, I don't think that the Express is anything special about it. It's just that, I mean, as far as I'm concerned, the Express is just a way to make a hole and sell you some money. And then that hole is supposed to give you some guarded flow. And I'm concerned the fact that people put an Express in, they don't really tie the flap down properly. So then we're having unguarded flow. And then whenever you do a filtration operation in a narrow angle patients, then you run the risk of malignant glaucoma because you overfiltrate. So I don't think there's anything special about the Express. And if I do a trap in a angle closure and I don't tie it properly, watertight, then I think I run the risk of malignant glaucoma. And I think if you believe the Express give you some titration of flow, but like an InFocus and a Zen of the early days, then I think you'll run into it. My question to you is that have you ever had malignant glaucoma in a non-penetrating surgery in some of these eyes? Because you also
Just
have an
once
unguarded flow.
Yeah, once in 20 years. It's relatively, I wouldn't agree with the unguarded kind of definition that you put, because you have the trabeculodesmoid membrane after a deep sclerectomy. So it is guarded in a certain way. But I had only one case develop intraoperatively, and it resolved with atropine, thankfully. But this is, I think malignant glaucoma after deep sclerectomy is extremely rare. I don't think that we published that, and they don't remember. Well, actually, we did publish that in our series of first 105 cases, but I don't think that there is any isolated cases that are published as case reports in the literature. I haven't read anything about that. My impression is that it's relatively rare.
But is it because that is normally avoided in people who hasn't got open angle? Unlike trabeculectomy.
I think you make a very valid point, because people who are using deep sclerectomy in narrow angle are very few. I'm still doing some cases in narrow angles, provided that the superior angle is open enough, or that I can open it with an iridoplasty, and that I'm quite worried about doing a trabeculectomy in those cases, because they're single-eyed, or whenever I'm scared in an angle closure, I would try to avoid a trabeculectomy, and I now would go for a phaco first. I mean, my mantra now is phaco first. I mean, it saves you so much headache and pain. I understand that malignant glaucoma can also happen after that, but still a trabeculectomy in a phakic patients in narrow angle, or an Express, or whatever you want to do, for me is playing with fire. I'm more and more abandoning that.
So I think there was a few questions during the talks that I answered, and people may not have seen. A lot of people were asking about phakic patients with malignant glaucoma and what do you do? And I do agree what you said, that I really wouldn't like to have a malignant glaucoma in a phakic patients, because you couldn't really do the iridozonal halodectomy in a phakic patient without priming the lens. So I think any of these people at risk, I would be keen to take the lens out. When the pseudophakic is easy to deal with. And I think once you made a channel of communication between the anterior and posterior segment, to answer one of the questions, if you made a full channel, I don't believe the malignant glaucoma will come back. When it does come back, which often means that your channel is blocked, then when you put a gonial on it, you'll be able to see that sometimes it's blocked with fibrin, then you can YAG it. And I have managed to successfully treat a malignant glaucoma that's recurred because my channel is blocked. That was one of the questions.
I have just one comment. Sorry.
Please go ahead, Ahmed.
Sorry, just one comment to Leon. Do you think, do you agree with me that some of these malignant glaucoma will still need core vitrectomy or proper vitrectomy by VR surgeon, even with this open corridor? Because I've seen few that have already had the anterior hyaloid taken, and this corridor is there, but still the aqueous misdirection occurred. So do you agree with me that still few cases still have to visit the VR surgeon?
I suppose the answer to that is always going to be yes. But then it's just whether we've created a good enough channel, and with, when you do the eyes, there's iridorsal hyalodectomy, you do stick your catheter in and do a core VT, and it's hard to understand why you would need to remove the bigger bulk of the vitreous if we've created a good enough channel and a good enough bit of anterior or a bit of a hyaloidectomy. But I'm sure that, you know, if you're not very extensive, you created a bit of a channel and you've not done enough, vitreous can still come forward and block it. So yeah, I'm sure that you're right, but I think it does sort out most of this problem.
Would you inject for any high risk cases like subchondral atropine on table and keep them for long term atropine? What do you
I
think?
certainly would give them atropine. I'll never give them subconj, but you know, I certainly would atropinize them. And I think there are patients that I atropinize without surgical intervention. They're elderly, they are in low-grade malignant glaucoma, they're suffering from myopia, but they haven't got pressure problem. They go on atropine for quite a while, but then after a while, the atropine effect does wear off.
One scenario where I would always atropinize is the fellow eye of an eye that developed a malignant glaucoma. So the fellow eye is definitely a candidate for atropine. Ziad, are you still with us?
Yep.
Ziad, a brief question. Has the micropulse changed the classical indications for a cyclomodulation or ablation?
Well, that's actually a very good question, because this is the direction that the company is trying to take, and most of the papers out there are focusing on, you know, early glaucoma, moderate glaucoma, and eyes with good visual acuity. I think we're not there yet. I would definitely not recommend this procedure, you know, as a primary procedure. I think we still need some time to develop better treatment parameter, better treatment technique, and a better safety profile to be able to broader the indications. So it's not a replacement for SLT or for glaucoma surgery yet.
I think regretfully I have to conclude. I'm really enjoying this webinar and sitting with those great surgeons and great friends. But we have our time limit. So I'd like to thank you all for brilliant lectures. Thank the participants, thank the audio-visual support that we have. It has been brilliant. Of course, the organizers in the Watany Eye Hospital. I think this is a great series. I hope that they are recorded and that we are going to share them extensively in the coming few weeks and months. So, as Rick said, stay safe. Life is going to be good again. And I hope you enjoy the rest of your night or days, depending on where you are in the world. Thank you very much for being with us. And till we meet again, good night.
Thank you, Tariq. Bye-bye.
Thanks, mate.